welcome to our first speaker for second day of our workshop, Dr. Benjamin Collins. And I will go with his intro first, and then we can start. So, Dr. Benjamin Collins is a physician and postdoctoral research fellow in ethics, legal, and social issues of artificial intelligence in healthcare with the Department of Biomedical Informatics and the Center for Biomedical Ethics and Society. Clinically, he works as a hospitalist with the Department of Medicine. He completed medical school at Virginia Commonwealth University School of Medicine in Richmond and internal medicine residency at Temple University Hospital in Philadelphia. During residency, he also earned an MA degree in urban bioethics from Temple with a thesis on a theory of socio-technical justice in healthcare. He then completed a clinical informatics fellowship at Oregon Health and Science University, along with an MS degree in biomedical informatics, finishing a capstone project by developing an online training module for clinicians on algorithmic bias in healthcare. He received the 2022 American Medical Informatics Association Academic Forum Best Paper Award for his work on development of an online training module on algorithmic bias in healthcare for clinicians. He volunteers as a member of the Diversity, Equity, and Inclusion Committee in EMEA and serves as the 2023-2024 Education Co-Chair for their Education, Governance, and Policy Subcommittee. So welcome, Benjamin, and your profile is really impressive once I was reading it. So it's a pleasure that you find time for our workshop, and the stage is yours. You can share a screen. Yeah.
Okay, thank you. 1 second, let me just get my screen set up. And let's see. Great. Does everyone see the slideshow here?
Yes.
Okay. Great. So again, Benjamin Collins, and as mentioned, I'm going to be presenting an overview of ethics and equity of artificial intelligence in healthcare. There's quite a lot of content to get through, but I'm hopeful that it will help connect many of the presentations throughout the workshop from both yesterday and today. No financial conflicts of interest to disclose. Some of the work here is funded by an NLM T15 training grant, and some work is ongoing or under review for publication. The agenda for the talk. So for the presentation, I'll begin with a brief reflection on the potential benefits and risk of AI in healthcare, followed by a statement on why there is a significant need for ethics and equity perspective in healthcare AI, along with key concepts to keep in mind, and a brief overview of related ethics and equity issues. I will then provide a canonical example of the realization of some of those issues outside the context of healthcare, where AI is further along in implementation. Next, I will introduce a healthcare AI lifecycle, a lens through which we can think about the issues of ethics and equity of healthcare AI, and then walk through some actual examples of healthcare AI systems and the issues of ethics and equity which have come up in those examples. I will end with a summary and a few difficult questions for reflection that we do not yet have answers for, but that we need to continue to spend time thinking about as AI becomes more widespread in healthcare. So to begin, the big reason why we are all here and having these conversations is that there's a great potential with AI in healthcare, what it might be able to do to help people by facilitating working with a lot of data that's accumulated within healthcare, working towards more accurate diagnosis and improved treatment plans, discovering new biomedical mechanisms or genetic correlations, or becoming more efficient and decreasing the burden on healthcare workers. On the other hand, we have also the great potential for risk of harm that come with the use of AI, which are reasonably gaining more attention. The most straightforward of which is that AI can be wrong, but there are a wide range of reasons why an AI system can be incorrect or why a human who uses an AI system may come to an incorrect conclusion from inaccurate data, automation bias of users not thinking about the output, a lack of explainability of the output, bias in the algorithms itself, or derivations of social biases, including race and ethnicity, sex, gender, or other biases. And other examples of possible harms include negative impacts on physician-patient relationships and digital inaccessibility of AI systems. So most relevant to understanding the ethics and equity of healthcare AI is thinking about how and where those risks originate. A large language model that produces an hallucinated output and a visual machine learning model that produces an incorrect diagnosis of skin disease are both incorrect and may result in harm, but the source of those risks, thus how we might think about them, are different in many cases. Um, Biased data contributes to the construction of a biased algorithm, the typical garbage in, garbage out scenario. But there may also be implicit biases of stakeholders that influence the development of the AI or lack of engagement with people who are affected by the AI, leading to not understanding how AI should be used, or poor oversight such that AI may masquerade as beneficial in healthcare when it is more beneficial for the company who developed it than for the people for whom it is used. This brings us to the need for an ethics and equity perspective in thinking about healthcare AI as one way to weigh the risk and benefits of AI, understanding that AI is here to stay with 692 AI applications approved by the FDA as of October 2023. Um, Through an ethics and equity perspective, we may analyze how to maximize the benefits of AI and avoid or mitigate the harms, and possibly address the harms at their root rather than simply circumventing them. We can also think about possibilities of healthcare AI that have not yet been realized, what policies or regulations might be beneficial, and how deeper, complex issues of ethics and equity may interact. Before we go on, there are a few key concepts that will be helpful to keep in mind. First, AI technology, and for that matter, technology more broadly, is not neutral. The potential for amplification or codification of existing biases into or by AI systems is most realized when there are not intentional efforts to not just avoid those issues, but to improve health equity. Patient and community engagement are essential when thinking about the ethics and equity of healthcare AI, as they are most often significantly affected by the use of AI in healthcare. But to this point, their values and perspectives have received insufficient attention. Nonetheless, patient and community engagement would allow for building trust and understanding of their goals to which AI can be applied. Healthcare is inherently multidisciplinary, and when engaging with AI healthcare, uh, different roles will emerge beyond those that have traditionally existed in healthcare, and other roles may need to adapt to new tasks. This reorganization of healthcare will also help to determine the roles that AI will have within healthcare. The last key concept, and this does not mean that there are not other key concepts, but just the ones that we will keep in mind in this presentation, is the role of AI as augmenting human provided care rather than substituting for it. AI is not at a level at this time where it can be broadly relied upon without human oversight. There are certain types of tasks that AI can do very well, even better than humans, but, and I'm reinforcing this again, AI still reflects human decisions. Like the name, um, sorry, now for a brief overview of ethics and equity issues of healthcare AI. So there are a wide range of ethics and equity issues related to healthcare AI, many of which are important, but that we don't necessarily have the time to discuss in a single presentation. To narrow the scope, I will briefly discuss four areas which were covered by Murphy and others in a scoping review: privacy, trust, accountability and responsibility, and bias. So the first thing we'll go over is privacy. And AI methodologies may rely on data to function as typically a large amount of data and for clinical uses. And it then makes sense that a lot of this is patient data. There's a lot of work done to de-identify the data to maintain secure data and separate key pieces of data. There's still a risk of re-identification matching patients with their data. This is an important risk because of the potential for harm. A lot of data may have associated stigma or carry potentials for misuse. Um, Reproductive health for women is a key area where this becomes important with the criminalization of abortion in many states. Other areas include gender identity and transgender care, immigration status, sexuality, HIV status, and mental health. Much of this data is typically collected by healthcare systems about patients, and with electronic health records, can be easily shared across institutions as well as across states. Another key component of this issue is at the intersection of privacy and autonomy, the question of who owns the data. There may be a natural instinct to suggest that the patient owns their own data, but this has generally not been supported by law. One must also consider how individual ownership of all patient data will prevent a lot of research, especially research on AI applications in healthcare, as it will require specific consent for every use of that data. But on the other side, there are many problems with insufficient patient control of data. And within privacy, there's a concept that I wanted to bring up called differential privacy. Essentially, it's shown in the graph here. The more people who participate and provide data, the less risk there is across the population for any one individual to be identified from a data set. But the smaller the subgroup is, the more risk there is for re-identification from a data set, so that an individual of a minority population uh, will always have a higher risk to be identified than an individual of a majority population. We're not going to spend much time specifically on trust, since the next speaker will talk more in depth on this topic. But it is helpful to consider here the correlation between patient trust in healthcare and their outcomes, and to think about how AI changes the trust dynamic, as patients will have trust in healthcare AI that may be influenced by their relationship with healthcare, but not necessarily correlate with it. And to provide some context, there's a small figure on the right, and you can see where previously there would have been a dyadic relationship between a patient and their clinician or the healthcare organization, which is becoming a triadic relationship between the patient, healthcare organization, clinician, and the AI system. Then, in thinking about accountability and responsibility related to healthcare AI, it's important to know from a regulation standpoint who has oversight of AI. In the United States, most clinical AI is overseen by the FDA. There's a layer of complexity, and the FDA does not have oversight over all AI, but we will keep it simple since nearly all AI with a direct clinical impact falls under the FDA. To learn more, you can read through what the FDA has provided in their reports, and I'll show a figure of their oversight process in just one moment. But before that, I did want to mention that currently the FDA reviews um, or approves only static AI systems rather than continuously learning AI systems, where static systems are AI that need to be manually updated. Uh, Whereas one of the main benefits that we see with AI is a system that can learn on its own and improve. But as of right now, those systems are not approved for use. Um, there's also issues with proprietary AI systems in that commercial organizations uh, may prevent their data from being seen by other by the public so that they reserve the knowledge on how the AI system functions. And despite that, as things currently stand, we consider clinicians to have the final say in terms of um, what AI or whether to use or not use the output of an AI system when performing clinical care. And then here, as mentioned, is the FDA process for review of AI systems. It's not the most straightforward process, but if you take a moment to review the process, you will notice that there is no review for equity or bias or anything of that nature. It's more about the general uh, efficacy of the system without really considering fairness. Now, we often think about AI systems as black boxes in which we don't necessarily understand how the AI systems operate. And when they provide an output, we don't necessarily know how the AI system arrived at that output. And again, we still provide the clinicians are considered the uh, to determine whether the output of an AI system is appropriate or not. And there were some talks yesterday that looked at explainability and whether an AI system uh, or a clinician using an AI system uh, was able to accurately use um, that system to make a diagnosis. And it was found that they were not able to do so when those systems were biased. And part of that was potentially due to the inability to recognize that those systems were biased. And then continuing on in with accountability and responsibility, we must also acknowledge that the field of healthcare AI is rapidly changing and that large tech corporations have a disproportionate amount of power in the direction that healthcare AI is going. These are three headlines from 2023 of large corporations doing work in healthcare AI. Google, Amazon, and Microsoft all making major deals related to healthcare AI in the past year. And then for bias, we generally mean by bias a systematic deviation from the truth rather than random errors. As briefly mentioned earlier, the largest source of bias in healthcare AI systems is uh, the bias in data, where unrepresentative data sets lead to conclusions that do not necessarily generalize across populations. And we'll get more into bias in a moment as well. Now go through some specific examples of AI and apply a life cycle of AI to ethics and equity issues. So first, an early non-healthcare example of problems arising from AI systems with the racial bias of the COMPAS system, or correctional offender management profiling for alternative sanctions. This was a predictive algorithm for the corrections industry to determine the risk of recidivism with widespread adoption, but was found to have Black individuals almost twice as likely as white individuals to be labeled high risk without later committing a crime. And now for the first healthcare case, which is based on an fundamental example of potential harm from the use of AI algorithms in healthcare, where Obermeyer and colleagues analyzed the use of a commercial risk prediction algorithm to identify patients for inclusion in high risk care management programs intended to improve the care for patients at high risk by shifting the distribution of resources to those who need them most. Or it ultimately led to the allocation of fewer resources for Black patients than similarly or less sick white patients. And we'll look at that a little bit more closely after going through the life cycle here. So uh, the image here shows 6 life cycle steps in the middle uh, surrounding patients at the core, and then 4 themes that are cross-cutting across all the steps. So briefly to go through each step. So step 1 is purpose. Initial step represents the purpose for which the AI system is built. This purpose could be a research question, a clinical question, commercial goal, government mandated regulatory goal, or other objectives identified by stakeholders. And there are any number of various stakeholders who may be involved in determining the purpose of an AI system, where the development of an AI system may be motivated by multiple objectives, ethical and um, ethics and equity issues may arise when these objectives are in conflict with each other. Step 2, data. So this revolves around the generation, collection, storage, provenance, privacy, and security of data used to build, train, and operate an AI system, where value decisions and accessibility underlie which kinds of data are selected. One key consideration is whether the data are representative of the population for which the AI system is intended to apply. The concept of representation can take on several meanings, but generally thought about from a demographic perspective, such as age, sex, gender, race, etc. Development. So the third step includes the technical development of the AI system, as well as the physical hardware necessary for the system to function. Decisions here include the digital and physical structure of the AI system, which features to include or exclude from the system, and determining how the system will function. This step also includes decisions regarding whom to involve in the development process. Step 4, validation. This step involves internal and external validation to ensure the AI system functions as intended. Internal validity refers to how well the design of a study fits a research question, the ability of a study to answer that question without bias, and how well an AI system matches its intended purpose. External validity refers to how well an AI system or research may generalize across populations. Fifth step, application. This refers to defining thresholds for implementation into healthcare workflows, ongoing decisions about when and how to apply AI, and the usability of an AI system. Questions of whether those who will be using AI and those for whom the AI is used and how they are informed and prepared are crucial. Step 6 is generalization, where this refers to the larger scale effects of the AI system on people and society, including the sociocultural context in which the AI system has been applied and the generalizability of AI to new contexts. Effects are often measured through population health and epidemiological methods, but understanding the nuances of how AI systems affect populations can require investigating through qualitative perspectives. Now, this is especially important for looking at how AI systems affect different populations. So for the cross-cutting themes, first, equity, which refers to the balance of an AI system effects on different populations, and equity needs to be intentional at every step, as AI is being applied to a context in which people are not equally situated from the outset. And it is important to acknowledge and, when possible, address factors that can influence equity um, uh, that are uh, within control as much as possible. Monitoring involves overseeing the development process and the impact of the AI system to ensure it achieves its intended purpose as an intentional evaluation at each step, and should be a process for reporting outcomes and errors. For feedback, this includes information returned at each step of the process and learning of the AI system from iterative use. And then the last theme, decommissioning, is the decision to discontinue or replace an AI system, which can occur at any point in the life cycle. And it should be noted that AI systems can be replaced with non-AI or non-technological solutions. Just because it's not a technological solution does not necessarily mean that it's a step. And the decision to decommission can be related to problems with the AI system, availability of better alternatives, high cost, or other reasons. Now, to return to case one, with the algorithm that was documented by Obermeyer, we can see where harms for patients originate at the data step because the data available in which the algorithm was developed reflected the influence of prior discriminatory practices and so did not represent the population to which the algorithm was applied or what was intended to be measured in the population. And it was then later at the development step that developers did not realize that this data was afflicted by historical inequities. And that ultimately led to the application of their algorithm and the inequitable allocation of resources. So in the second case, Liu and colleagues demonstrated the use of a generative AI large language model for automation of clinical decision support logic, which was input into ChatGPT to provide suggestions where ChatGPT showed a capacity to place inaccurate information into CDS alert logic. Here, harm primarily occurred at the point of application in the algorithmic processing of the CDS logic, while different or more data would not necessarily resolve the hallucination problem, which is presented by large language models, and harm um, manifested as hallucination in this case, and the inability to correct through the data distinguishes it from the first case. In a third example, we have an incident from 2016 where Google, DeepMind, company owned by the Alphabet, the parent company of Google, was in a partnership with a UK healthcare system. The NHS Foundation Trust was a semi-autonomous part of the UK healthcare system, in a public-private partnership to use machine learning to assist with managing acute kidney injury. Their partnership received a lot of criticism because patients were not granted agency of their data and there was poor protection of patient privacy. Further, Google would later take direct control and thus effectively transfer data from the UK to the US. This was only one of several major incidents over the past several years related to patient privacy of data. And in this case, the origin of the harm really goes back to purpose, as the intention of Google here was more to their commercial interest to develop to accumulate data rather than to necessarily work in the interest of the patients for which this work was intended to be for. Fourth example is the Epic Deterioration Index, which was an algorithm developed to predict deterioration from COVID-19 and other causes. It was developed by Epic Systems, which is the electronic health record company, and it was widely adopted without validation. It also, Epic provided financial incentives for the adoption of this model, but it was later found to underperform. And here, origins of harm, originating again purpose in terms of Epic having a financial incentive, and then also validation in terms of in this case, lack of validation, uh, which led to the adoption of an algorithm that did not meet expectations. In example 5 of in this case, a positive example. So human scoring of knee osteoarthritis severity based on radiographs has significant biases that result in disparities of treatment for pain for Black patients. Um, and an AI algorithm was developed with intentional equity, which improved results of the scoring um, and provides opportunity for more equitable surgical intervention. And here we have a benefit that originates at the point of purpose due to the intention with which the algorithm is developed to provide more equitable results. In summary, AI has the potential for both significant benefits and risk of harm, and the balancing of the outcomes makes ethics and equity perspectives essential, with key concepts to keep in mind that technology is not neutral. Patient and community engagement is essential. AI is inherently multidisciplinary, and AI is currently in a role of augmentation, not substitution. And there's a wide variety of possible ethics and equity issues that can come up in areas such as privacy, trust, accountability, and responsibility, and bias. When thinking about these issues, placing them into the context of an AI life cycle that considers the steps of the AI development along with cross-cutting issues such as equity can be helpful to understanding how those issues arise and how they may be addressed. That leaves us with some difficult questions to think about that we don't have answers for, such as how equitable does an AI model need uh, to be ethically applied in healthcare? How should differences in sociocultural values be accounted for in how AI models are developed and used? What do people need to know about AI, and how should they be informed about AI systems in healthcare and how they are used? And with that, thank you for listening. I've listed my contact info here and open for taking questions.
Thank you very much, Dr. Collins. It was wonderful to listen your research as well as insights on health equity and disparity. So now we will go with the Q&A session. So I have a couple of questions for you. Um, according to based on like your opinion or based on the research that you have done in this field, what do you think, which is more difficult to identify and detect? Data-driven bias or an algorithmic bias?
That's a good question. I think part of that depends on how the AI system is made. So, in the case of proprietary algorithms, um, when companies don't provide how their models are made, it can be really impossible to find the algorithmic bias. But similarly, like if the data is hidden, the same thing. Um, and assuming that both are available, I think that looking at the population from which the data was obtained, if you have those demographic data, is very helpful in determining the potential for a bias where it can be more complex to look at an algorithm and determine what biases may be present.
Okay, thank you. So as you said, like there are proprietary algorithms that being released from built by companies. So it's really hard to identify the bias in that stage.
Yeah.
So what do you recommend? What could be your suggestion to that the research community can do to actually mitigate these kind of biases? Yeah.
Yeah. I think the biggest thing is to form a strong foundation of advocacy. Um, is without uh, getting some form of power, whether that's through policy regulation or just the willingness, however unlikely, of companies to just uh, provide that data, um, there's not really much that can be done.
Yeah. Yeah, I think there should be initiatives on the policy changes, like European Union have some AI Act already implemented and passed, and they have some kind of restrictions on any type of algorithm being developed and what document has to be shared by the companies uh, to basically there should be some policy or regulation side of it to basically identify and mitigate these kind of biases.
Yeah.
Uh, so I have another questions. There are two more questions from the audience, so I will just go faster for that.
Okay.
So what do you think, what are the challenges currently to identify and mitigate these biases in the data set? And what should be the future research directions in this field, according to your opinion?
Yeah. Um, so again, the challenges. So aside from proprietary algorithms, there's also really one of the challenges is just being invested in finding those biases. Um, so again, like I mentioned that this is really like a multidisciplinary effort, and it takes a team effort to cooperate and say, sit down and say, what are the possible biases and what can we do to find and address those biases without everyone sitting at the table to do that. It can be easier to miss different biases that can come up. Um, and then in terms of addressing that again, just that mindset across disciplines. So healthcare providers, healthcare administrators, computer scientists, everyone coming together to make that a priority.
Okay, great. We have a wonderful question from the audience. So first one is from Destiny Pounds. Would you say that most of the current biases in AI systems for healthcare are due to a limited amount of patient data available? And another question, in your opinion, how can we encourage participation from minority populations, considering the greater risk of re-identification for those communities?
Yeah, great questions. Um, I, I wouldn't say necessarily that the most of the current biases are due to limited amount of patient data. I think, a lot of it is not, well, more on the side of a lack of complete data and a lack of being able to share that complete data. So if you get data from one hospital system and they have uh, a patient who gets care from three different hospital systems, but they don't have all of the data for that patient, it's going to be an incomplete amount of data. And then there may also be missingness of that data. Maybe the patient declined to provide their race ethnicity, or might have been inaccurately documented by a provider without actually asking the patient. So I think there's a wide range of reasons for the biases related to patient data. And then the second one, encouraging minority populations. That's definitely a difficult one. And I know it's one where there's a lot of work being done. Um, and I can't specifically comment on uh, the results of the work, but the All of Us program has been doing a lot to work on getting data from minority populations.
Okay, thank you. So another question from Lonnie Taylor. Um, you can also see on the chat, Benjamin, if it is too long when I'm reading. So differences in socio-cultural values should be highly accounted for as they affect the treatment of the individual. In the Black community, the majority of individuals' health and lifestyles are heavily determined by socio-cultural values and economics. Therefore, their physical constitutions are strongly correlated. Any model derived for that purpose should include this component as it accounts for an extreme amount of differences in the healthcare needs of these individuals. So, Loni, do you have a question or is it a comment? I do not find the question here. Okay, it's just a comment. Okay. So it's
Yep.
about the social determinants of health, I think, Benjamin, right?
Yeah.
Yeah.
Yeah. No, I definitely agree with this comment. And hopefully there will be more work to talk to communities about um, uh, what their expectations are, what their understanding is. And one of the issues that in one of the questions actually that I asked in um, is that we don't necessarily know what people understand about AI or how to tell them about AI so that we can have a full conversation. There are, I've seen several studies that um, some that avoid using the term artificial intelligence, some where the results make it clear that the participants don't have the same conceptualization of artificial intelligence as the researchers had, and that makes it very difficult to really understand those sociocultural values when we're not starting from the same place.
Wonderful, Benjamin, for your great insights and the talk. And we look forward to collaborate with you. We might talk later on because we are building this institute, and definitely there will be a lot of research happening in Mehari on these trustworthy AI in healthcare parts. So uh, thank you very much, and like you can uh, you can attend our workshop until 4 if you want to. There are a lot of speakers, or it's up to you. Thank you very much.
Yep.
Yeah.
Thank you.